Hello, everyone. This is Sadhana Alangar, HL7's Director of Education. Welcome to this presentation on Ayushman Bharat Digital Mission. Our speaker is Kumar Satyam. He is the Technical Committee Chair of HL7 India. He's also a past member of the Education Advisory Council of HL7 International. He's currently the Deputy Chief Product Officer at Karkinos. Satyam, what is ABDM? Tell us.
Thank you, Sadhana, and welcome all. Ayushman Bharat Digital Mission is an initiative by the government of India to build an infrastructure which can make the digital health journey of the country smoother. So it's actually enabling or building an ecosystem for digital health in the country. So what Ayushman Bharat Digital Mission envisions is to have interconnected, interoperable networks for the healthcare providers, patients, and other entities in the healthcare, so that the data exchange, the document exchange, the availability of the data for patient service, research, and so on and so forth is seamless, and that ushers the country into the next generation of healthcare delivery, right? So that's in short what is Ayushman Bharat Digital Mission trying to accomplish. So before we start, I will try to give you a brief on what's the current healthcare landscape in the country, right? So if I move to the next slide. Okay, so if you see, there are hospitals, diagnostic centers, clinics, public health programs, then there are software apps which are doing teleconsultations, appointment bookings, and so on and so forth, right? So there are so many healthcare providers, and then there are different softwares that they are using, right? So according to estimate and data published, there are more than 200,000 healthcare facilities in the country, which are supported by 2,000 plus healthcare IT vendors who are providing software to these entities in some shape and form, okay? And together, these guys are trying to look at or serve a billion plus population of the country, right? So, and what you see in the healthcare delivery mix for the country, there is a mix for both public and private health, which, and if you see the data says, like, for the urban, the private healthcare behavior or the private healthcare spend is more. 79% of the people visit a private healthcare in the urban areas, whereas in the rural areas, the number is not significantly down. It's at 72%, right? So this is what the healthcare landscape in the country is in terms of delivery and the number of health facilities, number of vendors, and the scale that we need to address, okay? So this actually presents some challenges which are inherent in the system because of its design, right? So first of all, there are so many disparate entities, and there is lack of trust between the entities, which means that each entity, each provider, each player wants the chunk of the patient. The patient for them is an asset, a customer, and they want to acquire the customer, work with them, protect them from going anywhere else, right? And which also means that you take all the services in the center, right? So you'd have seen, like, most of them, they don't even trust a lab test or anything that is coming out from outside, right? Then there is large population in the country, there is huge inequity, which also affects the quality, the uniformity of the quality of the care. Then there are multiple government schemes, and they have their own different processes. Most of the healthcare records, the EMR data, is actually on paper, and insurance, due to this, takes long time to resolve, right? And all this leads to a reactive approach to health management. So there is though the government is putting emphasis on proactive health management, moving towards the preventive, but the structure that is there actually is more reactive today. Okay, and this necessitates, this brings in the need for having a digital ecosystem where we can address most of these problems and actually get into a better shape. And that is how the ABDM was conceived. Okay, so before we get on to like the history of ABDM, how the ABDM was formed and all, I would show you some numbers which will just show you the scale at which ABDM is operating and the scale at which we are tackling the problem. Okay, so with that, I will stop the presentation for a minute and I'll move to my Chrome browser. All right, and just a minute. All right, I hope you can see my screen. This is the digital Ayushman public dashboard that is available. This dashboard presents or represents the daily numbers that are for the ABDM initiative, right? So if you see number of Ayushman Bharat health accounts, so Ayushman Bharat health accounts are actually unique patient IDs, right? So Ayushman Bharat health account is unique ID for a person in the entire country, unique health ID. So that's, if you see, it's close to 360 million now. So those have been issued, right? Similarly, you have around 200, again, it's around 260 million health records that are actually on the ABDM, right? And 201,000 health facilities have been verified. And similarly, if you see, like so many health professionals have been verified. Now, what is verified? Verified means, so in a registry, when you are building a registry, the trust in the registry is important. And what it means is that the data that is there is validated, right? So the verified registries for facilities and for health professional is an initiative or is a process through which a health facility or a healthcare professional like a doctor, nurse, or any healthcare provider are actually given an ID, okay? And also their ID is validated against the credentials they claim to have or the location or the facilities that they are providing. So when it says verified, means the ABDM process has taken care of making sure that the representatives or the health facilities that are named as verified, they have cleared all the checks, right? So that brings in more trust into the system. Now you know that there are 201,000 healthcare facilities which are verified, which are valid, and there are 161,000 providers who are actually verified, credentialed, right? So, but if you see from a relative terms, the numbers, so 360 million or in Indian terms, 35 crore number is maybe 1/3, or if we consider our population as 1.3 billion, it's not even 1/3, right? So we have not even reached 1/3. But if you see from just the absolute numbers, we have crossed number for several countries, right? So that's the scale at which ABDM is trying to do the transformation. Okay. health record linking, we'll see what exactly it means. What is an HFR? We'll see. Okay. And then this dashboard actually gives you the real-time data. It refreshes around every 30 minutes of how the digital journey is happening for each state. Okay. And then there are, so what other thing that has happened is like the digital health ID issuing. The government has actually made it such that even certified private sector players are able to help the government in generating the health IDs. Okay, and how is it that possible? That is possible because we had the infrastructure of Aadhaar. So Aadhaar, if you know, Aadhaar is the unique person identifier that runs in the country, and it's based on biometrics. And Aadhaar number is issued to close to entire population, or 99% of the population of the country. So everyone in the country has an Aadhaar number. Okay, and that Aadhaar number uniquely identifies that person. Okay, so using that Aadhaar number, the health ID is being generated. Okay, and since the infrastructure is in place, the certified partners are helping the government to do that. And then if you see the dashboard lists out like which program, which facility, or which entity has generated how many ABA numbers. Similarly, health record linked, who has linked how many health records. Okay, I will come to the term like what is the linking of health record, why I'm not saying sharing of health records, right? We'll come to that. Then there is just not that. So one of the problems that was there was like long OPD queues, long registration queues, right? So now, because we have a unique identifier in health ID, we have the facilities that are identified, we have the providers that are identified. It's very easy to have a registration that can happen through scan and share. And I'll show you how it happens, right? So those are the things that are being possible. I mean, if you see here, from the public dashboard itself, you can create your own ABHA. That is the Ayushman Bharat Health Account Number. That is the unique patient ID. If you are a facility, if you want to register yourself, you can go ahead and register yourself. Or if you are a professional, you want to register yourself, you can do those. Coming back to the presentation again. Okay. Okay. So coming back to the presentation again, the genesis of this ABDM. So ABDM is a new name for NDHM. Okay, so National Digital Health Mission was the original or the earlier name. Now it has been rechristened as ABDM, right? So the genesis, or if you see the roots of it, are laid in the National Health Policy of 2017, which talked about the challenges that the country has and the direction in which the country should move in terms of health and well-being. So how do you become from reactive to proactive, right? How can the health-seeking behavior move towards preventive, right? So that was the health policy, National Health Policy. And if you can read at the bottom, like you can read at the bottom the intent of the National Health Policy. Then National Health Policy talked about registries, federated architecture, data standards, and electronic health records and all. National Health Stack that came in 2018 built upon that and said like, okay, here is the policy, how should we implement it, right? That was the National Health Stack. Okay, and it was a consultation document. It laid out like what would be the architecture, how should you do the things, right? And then came the National Health Blueprint in 2019, which made a little bit more concrete design and implementation frameworks, right? And finally, ABDM was announced on 15th of August 2020 as a pilot in 6 union territories. Union territories in India are regions which are directly governed by the central government. Okay, and then after the pilot success, a year later, on 27th of September 2021, it was rolled out for the entire country. Right. So that's the journey, like genesis to like the launch of Ayushman Bharat Digital Mission. Okay. Now, what exactly is Ayushman Bharat Digital Mission trying to do? Right. So as I told you earlier, it is trying to build an digital ecosystem, digital health ecosystem, which can bring in efficiency in the system, make the system more affordable, accessible, inclusive, right? At the same time, have privacy and security as design principles. That's what ABDM's vision is. Right. So broadly, it is trying to do two things, or it aims to do two things. First, develop the backbone that is necessary to support the digital health ecosystem of the country, and then also ensure that there is a seamless exchange of health records for quality care. All right. Now, coming back to like some of the guiding principles of Ayushman Bharat. So today, the Ayushman Bharat or ABDM is a voluntary participation program, which means that citizens, health facilities, providers can choose to be part of the program or may choose not to be part of the program. Okay, so that's important. And then there is privacy and security in the design that is built in. It is built for inclusivity, which means that it does not only care about people who have smartphones or people who are digitally literate, but the mission is designed such a way that it is more inclusive and it takes care of the entire population. And then it's wellness centric, which means that more on the prevention, more on the education, more detect early, more proactive than reactive, right? Okay, this is stats we already saw. Okay, so now what we will talk now is like before we get into the architecture and the design of things, like how they are happening, we will just go through an illustrative workflow of how the things are envisioned to work, right? What the designers thought, like how the healthcare delivery would look like with ABDM. And this is just one of the use cases. There are multiple use cases that are there, right? So the first thing is to participate in the scheme or to participate in this mission. As I said, it is a voluntary mission or voluntary program. So a hospital or a lab, they need to be registered in the health facility registry to participate in the ABDM. So assuming that a hospital is part of the mission, a patient walks into the facility and they already have the health ID issued to them, right? The health ID is the ABHA ID, which we will see like what it is and how does it look like. Okay, so and in the health ID, there is a health ID number, there is a PHR address, and there is a QR code. So he just scans the QR health ID at the registration desk. As soon as the registration happens, as soon as the health ID is scanned, entire patient's demographics data that is required for registration, the hospital gets it directly, right? Just in one scan, right? Then once the hospital has registered and it has the Ayushman Bharat ID, ABHA ID, or the ABHA number, the hospital raises a request to the patient saying that I want to take a look at your previous health records. Maybe the doctor needs it, right? So the patient just receives the consent request on their mobile. They just approve it. Okay. And patient can choose here what data they need to allow the physician to see or what data they don't want the physician to see. Once that has happened, the doctor who is consulting and the doctor who is consulting this patient is able to see all the history of the patient and is able to make better diagnosis and treatment. When after the treatment, after the diagnosis, when the patient is walking off, the health facility can choose to link the record that has been generated now to the patient's PHR address, right? Now, the patient has access to not only his previous data, he also has access to the data that is just now generated. right? So that's one of the illustrative workflows that are being made possible through ABDM infrastructure that has been laid out. Okay, and all these things are live and they are in the works, means they are working. Okay. So before we get into the further workflows, I wanted to explain to you like how is it all possible, right? What is happening? Okay. So so this is the tech stack, or you can say like the 10,000 feet view of the ABDM stack. Okay. So the ABDM stack is built on the cross-cutting common goods infrastructure that that India already had, which means that we already had a way to identify people uniquely. That was the Aadhaar. As you know, UPI Unified Payments Interface is one of the success stories, or one of the most frequently used instant payment transfer mechanisms in the country. Again, that is interoperable. It's not a platform login, and there are many apps from Google Pay to WhatsApp to all who are enabling the UPI payments, right? Then there is already e-sign and other consent artifacts and all that are there already cross-domain that is being leveraged. On top of that, there are cross-cutting registries that are being built or has been built. Like, for example, health ID will be a registry that is required cross-cutting for anything. Similarly, professional registry, health facility registry, drugs registry, all those things are required for the infrastructure to work. So that's the stack, that's the lowermost layer, right? On top of that, then there are services, or the three broad categories that are there. One is like in middle, if you see, that is the health information exchange, which the use case that we are talking right now. The use case that we saw previously, the workflow, that is all the health information exchange, where consent-based health information exchange can happen. Health claims exchange is also in sandbox now, and it will enable digital settlement, instant settlement of health claims, including the claim adjudication and all the processes required. And then the third element is actually the unified health interface, which would enable like the outpatient services or the normal services to function, like telemedicine APIs, where you don't need to now be dependent on one particular platform to do the telemedicine. The provider and the patient can be on two different platforms, and still telemedicine would be possible. Similarly, for labs and drugs and other things, that is happening, right? That's the UHI interface. So these are like public owned, or these are government owned to some extent, to large extent, and they are built and maintained by the government. On top of that, if you see the user application layer, those are the ones where the private sector and the public sector is allowed to innovate. So all these things are open APIs, and these APIs are used to build applications on the top. So be it an HMIS system, be it a PHR system, be it a health locker, be it a UHI telemedicine app, anything and everything can be built on top of it, and they will be interoperable by design, because all will be using the APIs that are provided by the infrastructure. So that's where the innovation happens on the top level, the user application layer. Okay, and you would see the middle layer is called the digital public infrastructure. Okay. Now, if that is clear, then we will come to the middle one, and that was the health information exchange. Okay, because this is where FHIR is used, and we will invest some time to understand how this works and how this architecture is actually leveraging the diversity of the current setup to make interoperability happen or data exchange happen. Okay. So if you see, there are two roles. There is a role for health information provider. Health information providers are the guys who are actually the creators of the health information. So for example, a lab or a hospital or a clinic, right? Or a telemedicine. those guys are actually health information providers because they are the creators of the health information. Health information users are those guys who are the consumers of the information. Now, the consumers of the information may be the same guys, but in different role, right? For example, if a patient is visiting hospital 4, then in hospital 4 may require data that is generated in hospital 1. In that case, hospital 4 is a health information user and hospital 1 is a health information provider. All right. Now you see, all these hospitals, clinics, labs might be using different systems, like their HIS system, the LIS system, and they could be using any system. All right. As long as that system is enabled to talk to the central nervous system or the gateway, the ABDM gateway, the interchange is possible. Okay. So what it again enables is like, so the hospitals may not have to change a lot on their side. If they're using an existing HIS, they can just talk to a repository provider, which is again a software vendor, who can be ABDM compliant and who can also talk to their HIS and make, so that you can think of them as the bridge who can navigate between the ABDM ecosystem and the hospital, right? Some kind of an interfacing system, right? Okay. And if you see here, the red line, the solid red line is the data flow. Okay. And here you see the solid red line is the data flow. And if you notice, the data flow is happening peer-to-peer. Like hospital 1 is sending data directly to hospital 4, which means that the ABDM network, though it is mediating the data exchange, it is validating the consent and all, which we'll see later, but it's actually not privy to the data that is being exchanged. The data is being exchanged between hospital 1 and hospital 4. Okay. And the data resides at both the locations of health. So there is no centralization of data. So data stays with the creator. Okay. That is the federated architecture. On demand, the data will be shared. Okay. Now, how does the sharing of the health information happens? This is important to know. And I'll just show you through a interaction diagram. All right. So, for example, there is a hospital who would like to access to the medical history of a patient. Okay. So the first thing it will do is it will send a consent request to the health information exchange consent manager. Now the consent manager will do what? It will forward the request to the user or the patient. The patient grants the consent. Then the grant, that status is conveyed to the hospital 1. With that consent, again a request goes. Then consent manager forwards that request to the respective systems who have the data. And then the data is encrypted and shared with the requesting system. Okay. And if you see, the encrypted data is in the FHIR format. So what it means is we are not using the FHIR APIs. We are using the FHIR resources. We are using the FHIR bundles. We are using the FHIR documents. So just a differentiation that I wanted to make is like from the FHIR infrastructure, we are using the FHIR resources and the content, not the APIs. Okay. So now coming back to one question that you would have is like, if the data is there at the hospital, right? How does the consent manager know that there is data at this location, right? What is the way? How does it know? Because we did not talk about it. We talked about the health facility registry. We talked about provider registry. We talked about ABHA ID or ABHA number, but we did not talk about any kind of centralized storage, right? So how does the consent manager, which is in middle, know about where to look for data, whom the data should you should request the data from, and all those things, right? So for that, there is a concept called as health record linking. Okay, So what it says is like, so as soon as a hospital or a clinic or any health information provider, right, they see a patient, okay, and suppose there is a health record that is getting generated, the first thing that they need to do is not actually send the data, but actually send a notification to the registry, in this case the consent manager, that for the given PHR address or for the given ABHA ID, there is a health record or there is a care context that has been created at my location. Okay, so that's the linkage that the consent manager has, and through that it helps in entire identification of the data. Okay, so remember, the health facilities do not share the data with the ABDM, do not share the data with the registries. They just notify the registry that a particular instance of health record is available with us. Okay. Now, if you see the previous use case, we talked about a patient, or the use case that we saw, right? A patient already had an ABHA ID or they had a PHR address, they were able to scan. What happens if a patient does not have it, right? The first time patient goes, and as I showed you, like we have just around 30% or 25% coverage, right? So how do we get others into the mix? So this is what the first ABDM experience for a patient would look like. So for example, a patient goes to a hospital, okay, and the patient does not have an ABHA number or patient does not have a health ID. So in that case, they go to the facility, and the facility is actually a participating facility. They register their demographics. Then what happens is the facility itself notifies the ABDM consent manager, HICM consent manager, that a new record is there with this mobile number, because it does not know the ABHA ID. Okay. Now what happens is the ABDM infrastructure sends an SMS to the patient, and the SMS content would look something like this. Like your facility is participating in Ayushman Bharat and your report at this facility is now ready to view. So a nudge to the user to actually they can create. So when they click on the link, they will be shown a list of PHR apps that are supported. They can download one of the PHR apps and start accessing their records. Okay, so that's one of the ways how you can actually get users or get folks onto the system by a nudge, and then the nudge can come directly from the ABDM ecosystem. Okay. Okay. So if you see, now what are the steps to have the personal health records, right? So the first thing is the data needs to be created. Then there is a notification that needs to happen with the registry, the HICM. Then the patient should be able to view those records and then share, right? So if this entire long process is established, then we can actually have the personal health records movement in the country. Okay. So before we get onto the FHIR stuff, we will go back to our ecosystem, our things, and we'll see like how easy or difficult it is to generate a health ID. Okay. And that way we will see like what happens. Okay. So I'll again pause here. I will go to, I'll go here. So if you click on here, generate an ABHA account, it takes you to the health. And this is, so ABHA generation is also through various modes, right? As a person, I can generate my ABHA number. You saw that even the ABDM can send a nudge. Okay, the health facilities can generate ABHA numbers when a patient is getting registered, right? So there are multiple ways, both self and assisted, through which people can get the ABHA numbers. Okay, so here I, as a person, want to generate my ABHA number. So I go to the public website. there are only two modes available for a person, which is Aadhaar, either using Aadhaar or driving license. So I'll be using Aadhaar. Aadhaar is, again, as I told you, the health ID for the person ID for the country. So here, what I need to do is I need to enter my Aadhaar number. So let me see if I have my Aadhaar number copied here. Yeah, so I copy my Aadhaar number, I paste it here, and I give some consent, okay, and answer the CAPTCHA. And then there will be an authentication that will happen. That is an OTP that will come to my registered mobile number. So I'll have to see that OTP. Just give me 1 minute. Okay. Now what happens is, if the person already has his health ID, okay, the same health ID will be returned. If the person does not have a health ID, in that case, a new health ID will get created. Okay. Now, if I click on next, my health ID will be displayed. Okay. So now, since it is a PHI data, I would just click on it and then close it. So I click on it, and you see my health ID is there. It looks like this. Okay. And I will show you now how a health ID looks. Okay. So it has the 14-digit number on the top. Then it has a PHR address, and then it has a QR code. Okay. So if anyone is there from India, you can, and if you don't have your Aadhaar number, please go on to the website, click on it, and generate your Aadhaar number. Okay. So once, suppose, so this is how easy it is for a person to generate an Aadhaar number. So for a person who is generating an Aadhaar number or an Aadhaar ID, you don't have to go through any verification, anything, because your Aadhaar is your verification. So once you have the unique person ID, using that unique person ID, you can have your health ID. Okay. Now, so this is about the Aadhaar. Now let's see like what happens to the facilities. So one question that still remains in the mind, if you see, is like, how does the consent manager, or how does ABDM know this health facility has to be notified on this? What is the callback URL, or what is the endpoint on which you should talk to that hospital, right? That is something that is important to know. So for that, what happens is, if you go to the health facility, okay, you go to the any health facility that is there, and you click on the software linkage, okay. I think it's offline now, or I think I logged out. So here in the software linkage, you have to provide the, what do you say? You have to provide the bridge ID of the software that you are using to make yourself ABDM compliant. Once you do that, the callback URL will be listed there. Now that will be registered with the, again with the HFR, Health Facility Registry. So we using that, if any request is sent to you, that callback URL will be called by the consent manager or the gateway as required. Okay. So hope it's been clear so far. I think in the interest of time, I'll move a little faster. So coming back to FHIR. Okay. So as you know, and as I talked about earlier, if you see currently our systems, right, in the country, most of them are in various stages of digital maturity, which means that not every HMIS provider or LMIS provider or a clinic software provider has the capability to be structured, right? So where it can follow the standardized terminologies like LOING, SNOMED, ICD, etc., right? Most of them today generate PDFs, okay? But each one of the software, so for example, the labs and all, have the capability to share those PDFs with the patients, okay? So currently, that is the method that most of the healthcare providers are following, like where they have a method to generate ABDM and share the generate PDF and share the PDF, right? So what ABDM has said, like for the interim, for a limited period of time, it could be couple of years, 2 to 3 years, where they are allowing a limited window where the software providers can come on board, get certified with the PDF mechanism. So which will be like a document reference. In the document reference, you are attaching the PDF and then signing it off, right, as a FHIR bundle, right? Eventually, in a few years down the line, the mandate is going to come to have structured data, because if you have to do trend analysis or if you have to do any kind of analysis, we know historically the PDFs and the paper data is useless, right? But to exchange, to have some, to start a beginning, I think PDF is a good start, but slowly the mandate is going to come where all the resources, all the clinical artifacts that are being shared needs to be shared in a structured form. And for that, the FHIR structured definitions, FHIR bundle definitions that NRCS has defined will be used. Okay, so that's the currently the incremental approach that ABDM has taken. Now we just see the FHIR profile or the FHIR bundle that is there. I'll again go back. So if you see, this is the FHIR implementation guide for ABDM. And if you see here, you will find all the artifacts and the documents that are there. So today, ABDM supports these many documents, clinical artifacts that can be exchanged, all right? So wellness record, prescription, and other things. And then the details would be there. So they're all compositions. And then there are examples and all that you can see. Okay, so we can have example for each of those things. Similarly to what HICM is doing, or for the health records, there is another FHIR profile that is for health claims exchange. Okay, so this is still in 0.7.1, which means that it's still not released yet. But here you can find how we are going to do, how India is going to do the health claims through FHIR. Again, here the resources will be FHIR resources, but the APIs are different, not FHIR APIs. Okay. What I wanted to show you also is our sandbox, or the NDHM or ABDM sandbox, which is important for you to know, right? So as I told you, on the top layer, there is innovation, there is potential for private sectors to innovate, right? And for that, there has to be a robust support system, right? In terms of sandbox, documentation, then API marketplace, and all those things, right? So if you see here, this is the sandbox for ABDM. This is the documentation, okay? It lists out what all things you need to do, and let's see what is happening for FHIR. Okay, so if you click on here, so they talk about FHIR documents, and currently these are the FHIR documents that are being supported. Okay. Okay, and again, it's an incremental process. Slowly, we will get into more and more discrete data, right? Okay. And if you are an implementer, if you are implementing certain things, you can take a look at it. If you are building a HIP, what you should be doing. If you are building an HIU, what you should be doing, and certain things, right? Now let's click on one of the APIs, right? So all the APIs are available and they can be tested. So you need to give your client ID and the client secret, and you can start testing these APIs. The process is, first you apply for the sandbox credentials. Once you have the sandbox credentials, you build as per the spec. Once the spec is there, you go through a certification or testing round. Once you are done with the certification and the testing, you get the production keys. Okay, and then production, you will be there. Now the question is, how many systems are in production today? So that answer can be given by the dashboard. If you go to the dashboard, there are 98 vendors who have certified so far or who are in production. And then there are 601 healthcare providers or health tech companies who are in various degrees or various levels of maturity in terms of milestones they need to achieve. So again, ABDM has multiple milestones. The milestones are M1, M2, and M3. M1 is if you are able to work with the ABHA, which is like a generation of the ABHA, a verification of the ABHA, then you are an M1 compliant system. You can get a production key just for M1, right? But if you want to build an health information exchange, or if you want to build a system which can be used in hospitals and the clinics for data generation, then you have to apply for an HIP or HIU, and that is M2 and M3. Okay, so that's how it is. And now, if you want to see who are the partners that are already there, so if you go here, okay. So these are the companies who are already certified. Okay, so that's how it is listed here with their certificate, and the certificate will tell what exactly these companies are doing. Okay, so that's how the ecosystem is being built. Okay, now coming back again to our presentation. Okay. So this is the last slide that I will touch, and then we will open for questions. So what we saw so far, right, and it is a very brief overview of what ABDM is about. But in summary, there are like 5 components, 5 key components on which ABDM is being built, or which ABDM is building to support the ecosystem. The first one is the ABHA. ABHA is the unique identifier for a unique identifier for a patient or a person, right? Then there is a concept of PHR apps. The PHR apps are citizen or the patient facing apps through which you can have exchange and receive health data from all the HIPs that are you have visited. So if you have visited to 5 hospitals, then from the PHR app you can actually notify. So either those facilities would have notified the HIP, the HICM that your records are available, or you can have the option to just pull the records from those hospitals, right? Then registries, we have already talked about the health facility registry, health practitioner registry, the drug registry and all. Then the claims platform that is being built. And then finally, the entire HICM, right? These are the 5 main key components of ABDM. With this, I think we are open for questions if there are there. And based on that, we can go into details of any other topics that you want.
Lots of questions, 37 questions. Go ahead. If you can see the questions, you can choose. You may not be able to get to all the questions, but if you can choose the questions and answer, that'll be great. And then for the rest, we can send them the answers later.
Okay. So the first, I'll just go in the sequence. Is that okay? There are big questions. I'll go from the top. You mentioned data for research is patient data masked or otherwise made available for module training under this initiative, or just the advantages that we could draw. I don't know what's the question here. Under this training, or is it just the advantage? So, but in the ABDM, the initial initiative, there is a provision that is being worked out where masked data or anonymized data can be made available for various public health research or different research initiatives. The second question is, so how will this initiative address health inequities? This initiative will address health inequities in terms like it will make the care more accessible. And since the UHI and other things may come into play, it could be a uniform playing field. If the data is interoperable, then the lock-ins may not happen. So some of those things can access. The digital divide will be gone. So everyone will have access to their health data, whether they are literate or not. So those things are some of the examples that I can think of. But for more details, what I'll suggest is go to abdm.gov.in, and then there is a resources section in there where you can find more materials for that. That's the answer to Raja Krishnamurthy. Nitin Thakkar asks, so ABHA, the health account number, serves as the master patient index. The concept of master patient index is not here, but you can think of it as a master patient index, but it's the unified number that is there, and you don't need any other number. So in your hospitals, you might have MRNs and multiple things, but each patient, when you're having a record exchange, it will have a ABHA number. So you can say it is a master patient index, but what is envisioned is like there will be one unified number at the country level. Denise, Dr. Naveen is asking how FHIR working in ABDM. Is there any organization maintaining the APIs? So FHIR, as I showed you, like we are using the FHIR resources in ABDM. The custodian for the implementation guide is with NRCS. NRCS is a division under, I think, Ministry of Health and Family Welfare. Okay. The APIs are maintained directly by the NHA. Okay. FHIR, when India started adopting, can you please elaborate? That's the question. So FHIR, with ABDM since 2020, the push for FHIR is there. And with ABDM and HCX that is coming in, the FHIR adoption is happening. That's Dr. Naveen. Kiran is asking, does hospital need to have a FHIR-based EMR or EHR? No, the hospital does not need to have a FHIR-based EMR or EHR. That's not a mandatory requirement, okay? Because if they are having an health repository software or a provider who can help them translate their data into FHIR format and communicate to the ABDM, then they don't need it, right? But it always helps to be as native standard as possible. Is hospital going to verify my biometric? What if someone else uses my unique health ID? What is the preventive measures in such cases? Okay, so verification of health ID can be done through biometric or demographics. You're right. What if somebody uses unique health ID? So unique health ID can be used if you share your unique health ID, but the verification with the biometric will fail. The OTP, if the OTP is not there, then that verification will fail. And even if somebody is using your health ID, the data is going to be linked to that health ID, right? So it's up to the hospitals and up to the health information providers, clinics, to make sure that before they are putting in the health ID, they verify the demographics and whether the demographics are matching. And that's the M1 milestone. And that's the preventive measure that is there. More than that, it's not there. So if you have any specific challenges, then I think we'll have to report it to, or concerns have to be reported to the NHA, which they can answer. How did you incentivize providers to join the network? Again, I'm just a private sector guy, so I'm not speaking on behalf of ABDM. I am just an implementer and part of the HL7 India committee. And so in that respect, I don't have any visibility into how the providers are incentivized. But what I understand is certain PMJY and the health incentives. The government is looking for them to join the network to avail the benefits. But again, the disclaimer is I don't know about it. How do you address the issue of PII? So there is a Prachi question. So there is no regulation as such today. Okay, when it comes to privacy and security of PII data, we have the old regulation that is there in the IT Act, but a new one is coming soon. Once that is there, the safeguards and the guardrails will be in place. Is the exchange of FHIR message? Is the exchange for FHIR message? So what? We are using a FHIR version 4, R4 of resources and the bundles. That is the answer for Kiran. Vinith Mishra, is there an app briefcase used in the ABDM ecosystem? If yes, where does it fit in the ABDM stack? Briefcase is an app, and if I'm not wrong, it's a PHR plus Health Locker app. Okay, the better answer would be you can look up into the ABDM partners list, and briefcase would be listed there. You can just take a look at that. Someone from Anonymous, do all the HIP systems need to have FHIR APIs, or does the gateway allow other types of interfaces? APIs are required, but they are not FHIR APIs. The APIs are developed and maintained by NHA, and those APIs are not FHIR APIs. Okay, and there is today the only way of communication to the gateway is through APIs. And these APIs are not sync APIs, they are all async APIs, which means that when you say init, you have to have a callback URL where you get an on init, right? So none of these APIs are sync, right? So these are for scalability purposes, all these APIs are made as async APIs. Is the identification of patient based on biometric? The identification of the patient is based on, and this is again Prachi Mehta, the identification of the patient is based on the Aadhaar number, and Aadhaar number is created basis the Aadhaar number. And for getting the Aadhaar demographics, you would need either an OTP or biometric. Anonymous attendee, what are the most popular HIE platforms and used here to build the infra? Is FHIR acting as an interface or HIE itself? FHIR is acting as the data encapsulation standard. So the data, how the data will be encapsulated and sent from one place to other, that's what FHIR is being used in ABDM as of today. How are data exchanged from patient to hospital and vice versa? Do you use Loing SNOMED? As I answered, no for now. But in near future, when we are getting onto the structured data, we will be using SNOMED, which is the specification, which is the terminology that is mandated by the EHR standards. What are the common HISs in India? How many of, I don't have that answer. Prachi, so I have so many questions from Prachi Mehta. Can I go to the next? How long the consent is maintained and reused? For every request, the consent will be taken from users, that is Vensi. Yes, for every request, the consent will be taken from the user. The consent duration can be set by the users. Okay, there is a concept of a long duration consent also. In case you are a health locker or in case you are a PHR app, you might require a longer consent, but all those consents are managed, and patient is in charge of giving those consent. Okay, consents are so short period consents are timed, and you can decide what time it will be. Prachi, how do you address the patient consent digitally in a population that has limited literacy? That's a good question. Generally, what is happening is the hospitals or the health information systems, whoever is there in the health facility, they need to inform the patient what exactly it is and take the consent. So it's an informed consent that you have to take. I use FHIR. Could you share the profile? I already did share the link for the FHIR profiles. It is nrcs.in/abdm. Is the FHIR PHR app also developed and managed by the government? Government develops reference app. Okay, reference PHR app is developed by the government, but there are so many private sector apps developed, sort of. So government has just developed a reference app. Every HIP is mandated to provide linked e-health records. It is not mandatory. And since it is not mandatory to link health records, that's why now there is an incentive scheme that has come in where if you are linking health records, you are eligible for ₹20 per transaction. So that's the incentive that the government is giving now to link health records for the HIPs. Sadhana, the questions are not ending. How much time we have?
We are past time. If it's your call. I can stay back for another half an hour, but if it's your call, whether you want to answer the questions later. Yes, we can stop now and probably we can send the answers.
We can stop the questions. I can answer these many. And then I will. So I'll just go from the latest questions. Thank you, Satyam. Ajay Nair, one question. How do you think the use of structured data will evolve? It's a hard thing to guess, but any guess on how long will it be to take us? We can't guess right now, but it looks like it will take some more time, Ajay. It will take some more time. There has to be, I'm not sure, but there are some movements, some EMRs that we are seeing, they are coming up with good structured data, but you see like the breadth that is there, it's like 200,000 plus hospitals, facilities, and 2,000 plus vendors. So it is going to take some time. How is the database? How is the proprietary hospital clinical data transformed to FHIR bundle before displaying to the consumer? So here again, it's delegated to the hospital software how they are planning to do. So the ABDM network mandates that you exchange the data encrypted in FHIR format and you receive in the same. Now, how you manage internally is left to the EHR or the HIS vendor. That's the answer, Ganesh. How is the data security? How is the data security of the information ensured? Again, a couple of things on this. First of all, the data security, like the health data stays at the source. So it is as secure as the source who is generating the data. So if a hospital has enough security measures that are in place, it is as secure as that. When the data is being transferred from the information provider to the information user, right? Again, the data over the wire is encrypted. It's doubly encrypted, means it is transferred over TLS, HTTPS, and then again the FHIR bundle is also encrypted with the private key of public key of the receiver. So that way the data is ensured that it can be only read by the receiver, right? Now, after the receiver has received the data, again, it is the purview of the receiver how they can protect the data. So I don't think there is any requirements as such, like how the end users should protect the data. Could you please tell us on patient data retention by ABDM? ABDM does not have any data retention policy because it does not has visibility into any patient data. Any rules for data security, Dr. Naveen? As I told you, the sandbox, the specification talks about certain data security requirements that any implementer has to follow. So those are the data security rules that are there. Thank you for sharing. Congrats on such an impressive. How will the facility know to request data from a patient? Will they know some relevant care context? So here, Arjun, the answer to this is the patient might be telling the doctor or the clinician that I had a test that was done in some hospital, right? And based on that, the facility can request saying that give me the data for this period for this PHR address, or maybe it can specify some more details. Which countries can use FHIR, Fabino? I think today FHIR is a global standard, and I think a lot more countries are using FHIR. Yeah. Sadhana can answer that question better. Can patient have multiple health IDs, Mithun? So since the health, so there is a difference between health ID and so Aadhaar ID and Aadhaar number. So Aadhaar number is actually a unique number that is generated based on your Aadhaar. It cannot be duplicate. So you cannot have multiple Aadhaar numbers, but you can have multiple PHR addresses. PHR addresses are like they're like email addresses. So you can have multiple email addresses linked to one Aadhaar number, which means that as a patient, you can choose to share, saying that you don't want to link all your health record to one particular PHR address, right? So you can have saying if you have if some patients have mental disorders, they can have another PHR address. For general purpose, they can have another PHR address. So that's why Aadhaar number will be the same, but there can be multiple PHR addresses or the Aadhaar IDs. Health data security, I already answered. What is the security guidelines to be followed? Sharing data, answered. Thank you for overview. Can you share the implementation details on the consent management and security of? Yeah, I think I'm sure this is there in the presentation, and if you can look at the sandbox, there will be enough details there. So at the end of the presentation will be shared at the end of the webinar. Why FHIR APIs are not used for communication purpose? That's a good question. I don't have a clear answer to that, but they're not used. Maybe in some way down the line, maybe they can be used. And one of the things that I saw was like since, and again, it is totally a disclaimer, it's my personal guess or personal view. Most of the APIs that we have in FHIR, we are using sync APIs, whereas entire operation in ABDM is happening on async. That could have been one of the reasons. And yeah, and they wanted to have a clear bifurcation into like what will be a callback API versus what will be a init API. Maybe that is the reason, but I don't have visibility into why FHIR APIs were not used. We have been working with ABDM platform to get our HIMS ABDM compliant. However, struggling to get stable APIs from NHA tech side. I think there is developer support, and you might have got a contact person. You should just work with them. It should get resolved. I'll take more 5 minutes, those questions only. So Chris Taylor has asked, when hospital A receives patient record from hospital B, is hospital A allowed to store a copy of hospital B's patient care history in their own medical records, or are they required to requery it? So Chris, the answer is they can store depending on what the consent is. And if the consent, if the patient tomorrow asks you to revoke it, you may have to revoke it. But the guidelines are not very clear on that. Okay. So depending on the consent, you can the hospital A can store it. Does ABDM follow HIPAA guidelines? No. Why is the patient health history not centralized in its original form? What is the purpose of? So again, there is no centralization of data, because if you see the number of participating entities, right, and the volume of the size of the country and size of the population, any centralized store is bound to fail, right? And that's where the distributed or the federated architecture has come in. Okay. As I said earlier, there is no data that is being stored in the ABDM servers, apart from the care context, which indicates like what kind of data is present where. So actually the data always gets transferred from peer to peer. So there is no middleman who is having the data. Sylvester is asking, I think it was not clear to me, when you say the content is a FHIR bundle, but there are no FHIR APIs. I hope I have answered that, Sylvester. ABDM is using FHIR bundles or FHIR documents as the content, but the exchange APIs are like proprietary. So if you see in the FHIR terms, we have the FHIR paradigms, right? We have APIs, we have messages, we have documents, right? So they're using the document paradigm, but the APIs they have chosen to be their own, which is allowed. Who is the consent manager? Today, the consent manager is managed by NHA, the government. That's Mayur. Fenil asks what it is there for digital therapeutics company. I'm not sure about the question, but if you are a health information so therapeutics company, means a pharma company, I'm not very sure like about the question panel. Mayur Shah, will the user be able to access all their health records? Yes, Mayur. So the intent is that means once the network, it's a network effect. It's like most of the systems need to be on the network to actually feel that difference, right? So, but yeah, the intent is once most of the systems are on the network, then the user should be able to access all their health records, irrespective of where the health care was provided from their device. Can developers from outside India register for the sandbox? Aman Ish, I am not very sure about this. You'll have to just check with the sandbox. So you can apply for the sandbox and check there. Okay, I'm taking two more questions. That's it. So one is Selva Kumar Armugam. Hospital A talks to the consent manager to get patient data. Consent manager has all the links for the patient which reach out to other repositories and pull data. What is the consent manager technically? Where does it store all the document links? Okay. So Selva Kumar, I think I did not make myself clear. So I'll try to explain one more time. The consent manager does not store any health record links, or it does not store any information of how to access the data. It only knows which hospital or which health information provider has what data, right? That's all it knows, okay? It has that metadata. So since it knows the PHR address and it knows the hospital's bridge ID, using that, it can send the request or redirect the request to that particular hospital. Okay. So consent manager is actually a registry. You can think of it as a centralized registry. Today it is centralized, but tomorrow the architecture allows it to be multiple consent managers also to come into play, which actually mediates or is I don't get the right term, but which is actually mediating the data exchange. You can think of that. We can answer this offline because I think I need to explain it a little bit more to get the concept. How health tech companies will complete M2 and M3 milestone as they are not provider or facility. Health tech companies, if they are an HIP or HIU, means so if they are going to serve a hospital, right? So health tech companies as such, they will never be a provider or a facility, right? But health tech companies will work for or will provide solutions to a provider or a facility, right? That way, they will become or enable the hospital or the facility to become an HIP or HIU, right? And that's how they will get certified for. Yeah, thank you. I think I have answered most of the questions. If there are any questions that are remaining, I can answer them offline if I get those questions. Yeah, and thank you, Sadhana. So over to you.
Thank you so much, Satyam. It was an excellent presentation. Lots of interest and lots of discussions. Thanks everyone for joining us and asking your questions and participating in this webinar. I will send the questions to Satyam, and probably he can, if possible, you may want to answer some of the questions, Satyam. Not sure.
Yeah.
What do you want to do?
I can see.
I could send it over to you, and probably you can provide some answers if you want, if you choose to do so.
Sure.
Okay. Thank you so much again, Satyam. Thanks for your time, and thanks for taking the time to answer the questions. It's always wonderful to hear about the progress from my birth country, and this was such an excellent webinar. Honor to host this. And hopefully we'll see you in future events and classes till we meet again. Bye, everyone. Bye, Satyam. This is Sadhana Alangar, HL7's Director of Education, signing off.
Thank you.